Hello, my name is Ezekiel Oburu. I am an orthopedic surgeon in the University of Nairobi, and our topic of discussion today is physical injuries in children. Thank you very much. So physical injuries in children constitute about 15 to 30% of the fractures that we see in literature. Specifically in children, these fractures will be about 15 to 20% of major long bone fractures and up to over 30% of fractures in the hand in a child. What is the etiology of these fractures? Basically, we've got three main causes. The first is accidental trauma, where the child may be involved in various sporting activities, but also common in our setup is motor vehicle accidents or road traffic accidents. And then one should never forget non-accidental trauma, which is essentially another name for child abuse. And there are some pathological conditions, like for example, a child may have a bone tumor or something that they may need radiation, and this may end up destroying the growth plate. So how do we classify this fracture? You've had me say in other podcast episodes that I'm not a great fan of classification. However, there are some classifications that have stood the test of time. The Salter-Harris classification, which was developed in the 60s, has stood the test of time, and sometimes medical students or medical officers have difficulties in trying to remember this classification, but it's really not difficult. There are five main types. Type 1 is a separation through the physis. Type 2 is a fracture through part of the physis but with a metaphyseal fragment. Type 3 is a fracture through part of the physis extended through the epiphysis into the joint. And type 4 is a fracture through the metaphysis, the physis, and the epiphysis up to the joint. And type 5 is usually a retrospective diagnosis where you had a compression fracture of the growth plate, and usually you don't even notice a fracture has occurred, but the patient develops complications like physical bar, and the patient may have growth arrest or angular deformities, and this may actually show you that it was actually a Salter-Harris type 5 fracture. Now, Peterson also had a classification, and in Peterson's description, really, it's more related to the prognosis. However, the most commonly used the most commonly used description is that of Salter-Harris. Therefore, I would advise that you stick to the Salter-Harris. Now, where do these fractures occur? Now, if you look at the growth plate, it's divided into various zones. There is the germinal zone, there is the proliferative zone, there is the hypertrophic zone, and there is the endochondral ossification zone. These fractures tend to happen in the hypertrophic zone, but not exclusively in the hypertrophic zone. Now, let us look at some of the fractures specifically and what are the things that you do when you get these fractures. If you look at Salter-Harris type 1 fractures, these fractures, if they're non-displaced, really can be treated with a cast and immobilization. If they're displaced, a close reduction and casting will suffice. Salter-Harris type 2 fractures may be treated the same if really undisplaced. However, if they are displaced, then close reduction and casting is usually sufficient. Do we ever do fixation of this with percutaneous wires? Usually not, but some of them may entail using a wire, but most of the time really we don't need a wire. We just do this closed and casting. What about type 3? Now, there's an important element of Salter-Harris type 3 in the sense that this usually involves an articular component because the fracture extends to the epiphysis. So one may need to do imaging, or may need to use imaging techniques that will accurately delineate the articular component. These are like a CT scan. And what's a treatment? If the fracture is not displaced, then one may just choose to immobilize and cast. However, the fracture may be displaced, and really what applies to anatomic reduction of a joint injury will apply here, and therefore you may need to use either screws or a K-wire. What you want to avoid is, as much as possible, the screw or the K-wire crossing the growth plate. What about type 4 fractures? Now, these fractures really can be quite prone to a growth disturbance, and therefore really one should ensure that there is anatomical reduction of the physis and also anatomical reduction of the articular surface. Remember, if you don't get an anatomical reduction of the physis, you will very easily increase the risk of a physial bar formation. Therefore, these fractures should be anatomically reduced. It may mean that one may need to use a plate or a screw. Now, let me say one thing, and this I think is very important. You know, sometimes, especially in our setup, our patients may present late and they may present with a physio fracture. They may present after 2 weeks. What are some of the guidelines? During any manipulation of these fractures, really, you should try as much as possible to do minimal manipulation. In fact, a rule of 90% traction, where you just pull the limb for quite a bit of time, and 10% manipulation is a good guiding principle. Remember, if you've tried to manipulate this fracture and it's not getting into place, you know, you try more than twice, really, you're beginning to go in the danger zone where it's your manipulation which will destroy the growth plate. And some of these patients come, 7 to 10 days. Really, one should be very, very careful, with excessive manipulation at this time, because you can easily injure the growth plate. And then when you're doing your wires, please be careful. Try and avoid the growth plate as much as possible. So, what's a complication of this? Obviously, our complications, or the complications that we fear, is a patient may develop either limb length discrepancy or angular deformity because of a physical bar. And therefore, I think it's good to follow up this patient for about 6 months to 1 year after surgery, just to ensure that they don't have, either a deformity or a physical bar that has formed. How are you going to be able to detect if a patient has got physical disturbance? There are various imaging modalities, including a CT scan and an MRI, but really I think the gold standard now really is probably an MRI scan. Having said that, a CT scan may really aid towards planning for any further surgery. Obviously, surgery for this is in the realms of a pediatric orthopedic surgeon. Let me finish by saying that most distal radius, most physical injuries, I was thinking more about the distal radius because that's really the most common of the physical injuries. But most physical injuries heal without any problem at all. They don't have complications, some more than others. The proximal humerus heals very well. The distal radius, the rate of growth arrest is 4 to 5%. But if you look at the distal femur, it can be up to 50%, the proximal tibia up to 40%, and the distal tibia up to 40%. So thank you very much. That's the end of our podcast. I hope I've explained. I hope I've explained fractures, physical injuries quite adequately and simply. See you next time.